Hi guys, this is just a taster or a start of our teaching through Porter. I'm going to show you what kind of examiners you may face and how to predict and get yourself in trouble. The topic we're going to pick today is supracondylar fracture in a child. I will just start my slides. Give me a second. So what this is, it is basically how to survive your WIVAs. Okay, so let's see. So most exams starts with you cramming up all the lots of stuff that you need to remember, and especially a hectic push just a few days before the exam. On the day of the exam, you will find either you've not read anything or you're too scared to attempt purely because you're not prepared. The reaction from the examiner is either he is unhappy with you or he laughs at your misery. So hopefully by the end of this talk today, you will know how to get yourself out of trouble, okay? So this is the x-rays that one of my registrars that we've done a video with is going to be looking at. I'm not going to tell you what it is, I'll tell you at the end of it, but have a look at it. This is the x-rays that's been shown, and we're going to have a viva with him regarding these x-rays. This is how this was fixed. Okay, so the first session is have a look at this. This is one of our registrars, and Mr. Sadiq is taking his viva. So guys, you've had a video, you've seen a very good presentation from the registrar. He did tell you about the age of the child, the type of fracture, and actually left very little for Mr. Sadiq to interrupt until he asked his second question. Right, so before we go anywhere further, I'll give you this to look at. Did the candidate pass? Was the examiner fair? And if you had a choice, would you change anything? So I will show you the next video, and then the third video, and I'll come back in detail to see what was happening and how to get out of trouble, yeah? So this is the second part of the exam. It's the same patient, same x-rays, but we have a very aggressive examiner. So let's see what he says. Okay, so again, the same question. Did the candidate pass? Was the examiner fair? And would you change anything at all? Before I go to show you the third video, I will go back to the first video and I will show you how to pick reactions from an examiner. Okay, so if you go back to Mr. Sadiq taking the exam, and if you start from the beginning, you will see that Mr. Sadiq has asked a question, and as soon as he mentioned extension, the reaction on Mr. Sadiq's face changes. So you can see so far there is no body response from Mr. Sadiq. And you can see Mr. Sadiq's gone quiet. He doesn't want to say anything. So he tries to give a hint to the candidate. So remember, if the patient, the examiner goes quiet or responds something differently, you've said something wrong or he's expecting something else from you, okay? So now, if you go to see Mr. Sheikh, again, he has been nice and kind and quiet. And as soon as the extension word comes in, he completely loses it, okay? So he's not giving a hint. He's just being aggressive with the candidate, which is, again, something that needs to be changed. But you have examiners like silent death, which was Mr. Sadiq demonstrating, and then you have an examiner who's totally aggressive. Okay, so ideally we should have an examiner of this type. Okay, so this is an examination type where we have actually asked you the same question, which is a candidate, was he passed, was the examiner fair and change anything? Well, this is one of the examiners who wanted to pass the candidate. He was very helpful and he sort of corrected him and gave him an option that instead of the Gartland classification, what other types of injuries you know. So this is what we do with our guys who are doing exams. We grill them all the time and make sure that they have the answers ready and prepared for the exams. Hopefully your seniors will sort it out. There's loads of out there with keen interest, and hopefully they'll help you. While we are at it, I just want to complete the type of questions that can be asked in a supracondylar fracture in a child. So this was the original X-ray. If you can look at it, it's forward, not behind. So it's a flexion type injury. You can see it on that particular type. And the difference between the flexion type and the extension type was nearly all of the flexion type need to be fixed. However, most of the the extension type don't need to be fixed because the periosteum at the back will hold it, and so you can manipulate them, but occasionally you may need to fix them. So that's the big difference. They're inherently unstable. So in the first case, the candidate failed, although he did a very good viva, but he did not pick the diagnosis, and the examiner didn't help him. So this is what we call as a silent death examiner. He was taking you through, and you can actually feel you've done really well, but you've been taken up the creek, as they call it. So in the second case, the examiner was aggressive and angry, and he actually was upset at the wrong diagnosis. You will feel some examiners like that. That's a hint you need to take. Make sure that you can retract your statement and see if you can salvage it. Okay, and the third examiner was very helpful. He was guiding the candidate all the time and telling him and correcting him. So that candidate passed. The examiner is very fair, and you wouldn't want to change anything in that particular time. Okay, so hopefully you've learned something from this. So just a revision, there are two types of fractures, the extension type and the flexion type in children. And basically the flexion type occurs when the elbow is in flexion and is hit from behind. The extension type is the fall on the outstretched elbow. So the history will tell you what's happening. There is a Gartman classification. Unfortunately for you guys, there is a fourth bit added onto it. Everybody knows about the first one, which is a non-displaced, the type 2, the intact posterior cortex. If it's a flexion type, it will have an intact anterior cortex, but the classification is same. Type 3 is completely displaced, and then type 4, the periosteum is gone, and therefore you cannot reduce these, and you have to open them and fix them. Okay, so the thing to remember about the flexion type supracondylar fractures, they're very uncommon. They, as I said, because of the direct blow to a flexed elbow, you have nerve injuries here, and generally they do require fixation. So if you have a supracondylar fracture and you have a whole process and you talk to them about managing them non-operatively and all that kind of stuff, then you're obviously telling them about the extension type, not the flexion type, and therefore you may not have succeeded in that part of the table. Okay, you must know in the exam how to reduce them. Basically, you put them in traction for about 10 minutes with a 10 degrees less than full extension. Then you can, milk them. If you feel there's a puckering sign and there is a piece of tissue stuck into them, you can then do varus and valgus positioning to correct the alignment. And while you're flexing it and rotating it to use the triceps to hold it and the periosteum to hinge it, you need your thumb to push it back in. So this is something that you can maybe ask in the exam and you have to discuss. Okay. In the examination techniques, you will be asked to see what tells you or where it needs displacement. So this is, the first one is an undisplaced fracture, but it has a fat pad sign, which you may need to discuss and talk in the exam. You have to draw an anterior humeral line, which touches part of the humeral condyle to tell you that this does not need manipulation, is the undisplaced type. However, when you're very young, you will have an anterior line, but will not give you the right information. But as was discussed in the viva, then these are young children, and in young children, you don't have a supracondylar fracture. They're called transcondylar fractures, which is a totally different thing altogether. Okay, you need to know what a Bowman's line is, and you need to be able to say what it is and talk your way through it. Okay, if we're talking about elbows, you need to remember Kreiter, which is the classification to tell you how old the patient is and when the ossification senses are. These are all eponyms. You just need to remember them. It's 3, 5, 7, 9, 11, and Kreiter, capitulum, radial head, internal epicondyle, trochlear olecranon, and external epicondyle. Okay, so hopefully this has helped you, and hopefully you will know the process of the exam. You need to be able to read the examiner, his body language, and see what you're saying is registering or not. Hopefully we will have more of these, but this is just the beginning of what I want to show you and what all this exam business is.